Welcome to the Survive and Thrive education series on LGBTQ plus survivorship. My name is Lindsay Murdoch, and I am a clinical oncology social worker with the Cleveland Clinic Taussig Cancer Institute. Today's presenter is Amanda Schmiedl. Amanda is a physician assistant specializing in oncology at the Taussig Cancer Center, where she has been part of the team since 2019. Her clinical focus is on inpatient care for patients with solid tumors. In addition to her clinical responsibilities, she has served as the inpatient advanced practice provider manager since 2024. Amanda, thank you for taking the time to present this topic today.
Hi, Lindsay. Thanks for having me. Um, so as Lindsay said, I will be talking to you about LGBTQ plus survivorship. So here is just, further introduction. My name is Amanda, and with me today we have Lindsay. So our agenda for today will be to discuss the definition of sexual and gender minorities, the barriers that this population has to cancer care, some unique risk factors associated with this population, and then LGBTQ plus specific cancer screening and survivorship care. So to start, kind of who is a survivor? And so we define the National Centers for Cancer defines a survivor as any individual from diagnosis through the balance of life. So those living with cancer and those free from cancer, which sometimes can be surprising to some people who, may have a more narrow view of who cancer survivors are. But if you are alive and have experienced cancer and are currently experiencing cancer, we consider you a survivor. So how do we define sexual and gender minorities or, our LGBTQ plus population? So this is an umbrella term that the National Cancer Institute has defined as anyone who is lesbian, gay, bisexual, transgender, queer, intersex, asexual, as well as people who identify as neither heterosexual nor cisgender. So it is a very broad term, and it allows us to be inclusive of all people who may not fit into, a heterosexual and or cisgender box. So here is this acronym that, this umbrella. So queer is meant to be an umbrella term that kind of encompasses both sexualities, such as lesbian, gay, or bisexual, as well as genders, transgender or, asexual. Historically, queer has been a term that has been used in a derogatory way to hurt people or to cause negative feelings. But more recently, in the past couple of decades, some LGBTQ people, including myself, have reclaimed the term to describe our sexual orientation in a more broad and self-affirming way, since it encompasses more than just maybe one label. And then here we have the genderbread person by a nonprofit group called It's Pronounced Metrosexual. And it really helps us understand the difference between sexual orientation and gender identity, which is important when it comes to your care within the healthcare system. So your gender identity is a person's internal sense of being. So whether you identify as a male or a female or both or neither, that is kind of how you identify yourself as being, whereas sexual orientation kind of describes how you characterize your sexual or emotional attraction to others. And they don't always align. So gender does not always equal sexual orientation. And, there is, as you can see, um, kind of a scale to this, or a spectrum of, kinds of a spectrum of womanness or manness or femininity or masculinity, as well as, kind of a sexuality spectrum or a romantic spectrum in terms of women, attracted to women or feminine people, and male attracted to masculine or male people, or vice versa. So, why is this important? It's important because sexual and gender minority people report less satisfaction with cancer care, and are more likely to have experienced discrimination in healthcare. Um, as well as transgender and gender diverse individuals are less likely to be up to date on their recommended cancer screening test. And this is important because this can lead to worse, healthcare outcomes, um, for these patients, which is important to us in the healthcare field because we, want to ensure that everyone is getting, equal and fair treatment, and equal access to cancer care. And so we, as your healthcare team, play a really important role in the assessment of health risk. And we need to understand the unique needs of this sexual and gender minority population, so that we can help guide you on your journey and make sure that you're getting the care that is appropriate for you. So the American Society of Clinical Oncology, which is a very prominent society within, the hematology oncology field, um, has identified that, sexual and gender minorities, including individuals who are lesbian, gay, bisexual, transgender, and intersex, bear a disproportionate cancer burden, due to, multiple factors, including discrimination, patient-provider communication gaps, and gaps in quality of care. And so we have been able to identify this. And so now we are, working hard to reduce this burden. So, what are the barriers to cancer care for this population? As we kind of touched on in the previous slide, discrimination by healthcare providers, whether that is, intentional or unintentional. Discomfort caused by gender-labeled oncologic surgery services, such as, um, Women's Health Center, or, Women's Breast Center is something that has been identified, given that, mostly those assigned female at birth, have, the majority of cases of breast cancer, but this can lead to, some discomfort of those who may, have be assigned female at birth, but not feminine presenting. Stigma related to this minority, lack of cultural competency of healthcare providers, and just the fact that they're more likely to be uninsured, and of lower, socioeconomic status. This can be because of their socioeconomic status. It can be, because of the barriers to, marriage and kind of the healthcare system in our country of how people are insured. Um, and unfortunately, 33% in this National Center for Transgender Equality US survey, found that 33% of transgendered persons in the US reported one or more negative experiences with healthcare providers, which is really unfortunate and hopefully something that is decreased now, given that that survey was, about 10 years ago. But also, misgendering, dismissal of concerns, difficulty in changing name and gender in healthcare registries and medical charts, which can cause, a discomfort and discrimination, again, maybe unintentionally, and just a lack of general knowledge by healthcare providers of transgender, um, or sexual minority cancer related issues, which represents, a further barrier to cancer care. So, these sexual and gender minority population does have some unique risk factors, including a higher prevalence of tobacco and alcohol consumption, high rates of infection with HPV and HIV, um, and the knowledge that gender affirming hormone therapy may have possible associations with carcinogenesis, which is cancer formation. So incident rates among transgender women, so those assigned male at birth compared to cisgender men, were higher for viral infection-related cancers. So cancers um, directly related to HPV and or HIV infections. Um, and transgender men, so those assigned female at birth, were more likely to be diagnosed with viral infection-related cancers compared to cisgender men in a 2023 study. So tobacco and cancer, is a well-established risk factor, and smoking can cause cancer almost anywhere in the body. So, you know, aside from, lung, which is the most common that we think about, smoking has been known to increase your risk of bladder cancer, cervical cancer, GI cancers within, the colon, the esophagus, the liver, the stomach, the pancreas, as well as, mouth and throat and kidney. Um, so it's important to know that, anyone between the ages of 50 to 80 who currently smokes, or who quit smoking less than 15 years ago with a smoking history of at least 20 years, should, be seeing their provider for a screening low dose CT to screen for lung cancer again. So if you have, if you're between the ages of 50 and 80 and you currently smoke or have recently quit, you should be talking to one of your healthcare providers, whether it's your PCP or your current cancer doctor, about, getting a screening CT chest to look for, lung cancer. And then screening colonoscopies are recommended for anyone 45 years of age and older with normal risk or younger, depending on your familial risk. But again, talking to your provider is really important, given that we know that this population, has higher incidence of tobacco use. Along that same line, again, drinking alcohol raises your risk of getting several types of cancer. This is, again, a very well-established risk factor. And again, it can cause, cancer throughout the body, potentially. So again, GI, like mouth and throat, esophagus, colon and rectum, liver, stomach, pancreas, but also prostate and breast cancer. So if you were assigned male at birth and you have a prostate, um, you should be getting prostate cancer screenings. And, anyone, but especially those assigned female at birth, should be getting, breast cancer screenings. So virus-associated cancers are a little bit more nuanced, but these can be HPV or HIV associated. And those with these, HPV or HIV viruses have a higher incidence of, several types of cancers, including Kaposi sarcoma, which is a cancer of the lining of the blood vessels and the lymph vessels. So, the blood vessels and the lymph that drains fluid. And it's often linked to immune deficiency. So those with HIV or AIDS, but also those with immune deficiency for other reasons, such as being on, an immune medicine, for something like, Crohn's disease or colitis. Um, Anal cancer, which is both HPV and HIV associated, but also can be another risk factor for this is repetitive anal intercourse. So, those who participate in repetitive anal intercourse, such as, males who have sex with males, are at higher incidence of anal cancer. And again, the stigma, around this can lead to, a barrier to screening for this, but it's really important that if that describes you, that you have an open conversation with your healthcare provider, given that we know that this is a risk factor for anal cancer. Non-Hodgkin's lymphoma has been found to be HIV associated. Um, Pharyngeal or throat cancer is been known to be associated with HPV. HPV is also associated with cervical cancer in those assigned female at birth. And then liver cancer or bile duct cancer can be seen in those with hepatitis B or hepatitis C, in those with, IV drug use. And so, having safe access to needles, safe access to hormones. So not just in IV drug use, but, those who are using hormones for self, gender affirming care, making sure that you have safe access to needles when using those hormones as well. Um, and so unfortunately, we see a higher incidence of these cancers in sexual and gender minority persons compared to cisgender heterosexual men and women. We do have a vaccination for HPV, and it should be routinely recommended to all children and adolescents 9 to 12, um, or young adults 13 to 26 who have not been previously vaccinated. So, I mean, this is an adult audience, but if you're under the age of 26, I mean, you have not been previously vaccinated for HPV, regardless of sexual orientation or gender identity, you should be talking to, one of your healthcare providers about if the HPV vaccination is eligible for you. Um, and then for those assigned male at birth, or yeah, those assigned male at birth are those, males who are having sex with males, having a yearly digital rectal exam to, assess for anal cancer or anal tumors. Again, it's not a comfortable exam necessarily, and there is some stigma, but um, early detection saves lives, and it is something that can be done, in an office setting, with or without a chaperone, very quickly, and we can hopefully detect it earlier. Um, and then if you're a male seeking a male, we additionally recommend anal pap smears for HPV and or HIV positive patients every year, um, or every 2 to 3 years, if you're HPV or HIV negative. So regardless of your infectious status, if you are a male seeking a male, you should be talking to your doctor about DREs and anal pap smears, given that repetitive anal intercourse is a risk factor for anal cancer. And we do have, multiple modalities to screen for this cancer prior to it, really causing a lot of like symptomatic obstruction or spreading. And then in terms of gender affirming hormone therapy associated cancer, um, there is not there is this risk of possible association with cancer formation, and so this 2019 study of over 2,000 adult trans women, so assigned male at birth, and 1,200 adult trans men, so assigned female at birth in the Netherlands, showed that there was a 46-fold higher rate of breast cancer in transgender women compared with that estimated rate in cisgender men. So some concerned that maybe, the use of estrogen or, feminine hormone therapy in transgender women can potentially increase the risk of breast cancer. Um, Given that mammary development in transgender women on gender affirming hormone therapy is histologically identical to cisgender women. So when, a transgender woman starts, gender affirming hormone therapy or feminizing hormone therapy, that breast tissue that develops is histologically or like molecularly, cellularly identical to cisgender women. And we know that cisgender women have a higher risk of breast cancer than cisgender men. And so that is kind of where that association lies. So there are multiple published reports of both non-cancerous and cancerous tumors um, in transgender women on growth gender affirming hormone therapy. So if, you are a person who is on gender affirming feminizing hormone therapy um, with breast development, it's really important that you, again, talk to your provider, advocate for, breast cancer screening, which I'll talk about, given that we know that, there is some risk possibly associated with that, and to make sure that you're being screened appropriately, given that your risk is elevated once you start that therapy. So trans feminine breast cancer screening. So if you are a trans woman with 5 or more years of gender affirming hormone therapy, you should have, an annual screening mammography starting at 40 years. Less than 5 years of hormone therapy, no screening is recommended. Based on our data and our research, no screening is recommended under 5 years. That's kind of the timeline where we know that longer duration of estrogen exposure to the breast increases breast cancer, and that 5 years is kind of where the risk starts to exceed what would normally be for cisgender males. So once you hit that 5 year mark, you really should be undergoing annual screening with mammography. And then if you are a trans woman at high risk due to genetic predisposition or prior chest radiation or strong family history, regardless of how long you've been on gender affirming hormone therapy, you should consider getting screening mammography starting at 25 to 30 years old. So, and again, these are the NCCN breast cancer guidelines. And NCCN, they they endorse, these the NCCN breast cancer guidelines are for persons assigned female at birth with residual breast tissue. There is the American College of Radiology appropriateness criteria. That's where this is coming from. The ACR, the American College of Radiology, and the NCCN endorses these guidelines. So these guidelines were created by the American College of Radiology, and the NCCN agrees with these guidelines. So that's where we get these from. And then additionally, 60% of trans women desire breast augmentation. So for breast implants, just following screening based on risk as previously, based on, length of hormone therapy. And free silicone injection, those, trans feminine patients with free silicone injection should be getting screening with a breast MRI. And of note, silicone injection is illegal in the US. But unfortunately, given, historically difficult access to healthcare and the stigma associated with healthcare in the US, it's not uncommon for those in the sexual and gender minority population to receive healthcare outside of the US and receive these injections outside of the US. And so again, important for you to talk to your provider, be honest with your provider if this is something that you have undergone, so that we can ensure that the imaging that you're getting is appropriate for your situation, so that we can ensure that we're screening you appropriately and safely, based on your risk. And then, of note, we know that breast implants, there is some breast implant associated anaplastic large cell lymphoma. And so again, just being, open with and honest with your healthcare provider, so that we can ensure that you're being screened appropriately. In terms of prostate cancer screening, for those assigned male at birth, trans women have a prostate gland regardless of pelvic gender affirming surgery status. So if you are a trans woman who have had pelvic gender affirming surgery, you still have a prostate. And so you should still be having, prostate cancer screening. Prostate exams can be performed rectally or through a surgical vagina. Um, if you're on feminizing hormone therapy, you may have lower PSA levels. So a PSA may or may not be appropriate for you. Unfortunately, no trans-specific screening guidelines for prostate cancer exist, but at the Cleveland Clinic, we do have, our Center for LGBTQ Care, who, we can collaborate with our Cancer Institute to work and decide, what would be the most appropriate and safest screening for you. But, if you were assigned male at birth, regardless of your hormone or surgery status, you still have a prostate and you still need to be screened for prostate cancer. And then the risk of masculinizing growth, gender affirming hormone therapy, so testosterone in those assigned female at birth, the risk is unclear. There was a study done in 2021 that did not find any clear risk. So again, unclear, but if you were assigned female at birth, you have breast tissue, you should still be getting breast cancer screening. Chest reconstruction or top surgery in those assigned female at birth for gender affirming care and masculinization is not equivalent to an oncologic double mastectomy, as residual breast tissue is still present. So oftentimes, it is not as a chest reconstruction or a top surgery. It does not It's not as complete in terms of resection as an oncologic double mastectomy, especially based on body habitus. Residual breast tissue is, left at various amounts or volumes. And so the risk of breast cancer in residual breast tissue is unclear, especially in those also undergoing gender affirming hormone therapy with, testosterone. But there have been incidental findings of high-risk lesions and carcinoma in residual breast tissue after chest contouring surgery. And so we do recommend, culturally sensitive breast cancer, exams and screening with, mammography and or breast MRI in transgender men or masculine centered gender nonconforming individuals, given that you were still exposed to estrogen, in biologically prior, to your gender affirming care. So that is important to note, that just because you had chest reconstruction, that does not mean that you no longer have breast tissue, or that, your risk of breast cancer mirrors that of a cisgender man. So transmasculine breast cancer surgery, those on gender affirming hormone therapy, so like testosterone without chest reconstruction, should follow screenings based on risk. So that would be, breast mammography, starting at 40 for low risk patients, or earlier for those with high risk based on, previous chest radiation or family history. But those who have undergone chest reconstruction should have yearly chest physical exams by a healthcare provider for possible palpable lumps. And these patients should be doing monthly self chest exams, with the residual breast tissue, to identify any self palpable lumps or changes to the breast tissue of yourself. So in terms of imaging, so those transmasculine patients with who have undergone chest surgery normally have residual, you will have residual breast tissue, but typically it's not enough to warrant a diagnostic mammogram. And we know that a mammogram may be traumatizing for some transmasculines, given that it, is a historically feminine procedure, or in, a women's health clinic, or with, feminine or women-based, signage or verbiage. Um, and so typically these patients will undergo, a diagnostic breast ultrasound at a breast imaging center, um, initially, plus or minus a breast MRI. But again, talking to getting, at least starting with this physical exam and talking with your healthcare provider about whether additional imaging is warranted or necessary, pending your individual risk and your physical exam findings. So what does cancer survivorship care look like? So in general, for all of those in cancer survivorship, we want to look at secondary cancer screenings, heart disease, lung disease, kidney disease, vascular disease, lymphedema, diabetes, sexual health, mental health, financial burden. All of these things are impacted by cancer care. Those who have received chemo and radiation or reconstruction may be at higher risk for secondary cancers. We know that cancer treatment can increase risk for some, heart, lung, kidney, and vascular disease. And we know that sexual health, mental health, and financial health is greatly impacted by cancer care. And so I'm not going to belabor this too much, because I know that, we have a lot of good talks on sexual health and financial health. But we are sensitive to this, and we know that those in sexual and gender minorities may have some unique barriers to survivorship care. So we know that cancer survivors are at higher risk for chronic health conditions, and physical and cognitive limitations, and that LGBTQ plus cancer survivors have an elevated burden of all chronic health conditions and disabilities. Um, and so this chart shows, it was a study of 41,000 cancer survivors. 1,700 were LGBTQ plus. And of those, the LGBTQ plus survivors had significantly higher age-adjusted prevalence of all outcomes. So as you can see, the LGBTQ plus patients are in blue, the non are in orange, and you can see, the percentage of those cancer survivors who identified as LGBTQ plus had higher incidence, markedly higher incidence of cognitive limitations, depression, difficulty walking, difficulty running errands, being independent in their lives. And so, this includes heart disease, asthma, COPD, kidney disease, stroke, diabetes. And we know that some of this is because of just the general barriers that we talked about previously. So, higher rates of being uninsured, overall lower socioeconomic status, stigma, but also, higher rates of tobacco, cancer, or tobacco, alcohol, and drug use. So, we are definitely sensitive to the fact that, us in the LGBTQ plus population, will likely have higher needs as survivors, and may need closer follow-up care, more specialized care. So our survivorship visits, will help you transition from active treatment to surveillance, to help you deal with short and long-term side effects, personalized ongoing plan of care and cancer surveillance, as well as cancer prevention and healthy living. And again, we know that our LGBTQ plus population, are going to have a higher prevalence of, complications, not complications of, chronic disease burden afterwards. And so it's really important for us as your healthcare team to stay by you during this journey to ensure that, you know, the other, you know, health, um, diseases in your life, like hypertension, high blood pressure, COPD, asthma, diabetes, are adequately being treated, as well as, you know, continuing cancer surveillance, because we know that cancer surveillance is disproportionately low in this population. Um, and cancer survivors are less likely to be screened for other cancer types, both those in, you know, sexual and gender minorities and those who are heterosexual and cisgender. So 65% of breast cancer survivors are never screened for colorectal cancer, 40% are never screened for cervical cancer, and 50% of colorectal cancer survivors are never screened for breast or cervical cancer. And so these, are numbers that we're definitely trying to lower, because just because you have gotten treated for breast cancer or colon cancer, doesn't mean that your risk for the other cancers, you know, is decreased, and in fact may be increased in some cases. So my key takeaways for today, I know this was a lot, was essentially, if you have it, get it screened. So if you have a cervix, you need to be being screened for cervical cancer. If you have a prostate, you need to be being screened for prostate cancer. If you have breast tissue, especially those who have been exposed to high levels of estrogen, either as assigned female at birth or those assigned male at birth with greater than 5 years of feminizing hormone therapy, should be undergoing, you know, yearly breast cancer screening. Um, but overall, you know, sexual and gender minority persons should follow the same cancer screening recommendations as their non SGM counterparts, aside from, you know, what I previously said kind of about breast cancer. But, you know, there are definitely additional considerations, as we said, you know, smoking history, you know, alcohol use history, hormone therapy history, surgical history. And it's important for us to provide you with culturally sensitive care, especially because we know that, as you know, a trans feminine woman, um, or person, you know, uh, receiving prostate cancer screening may be uncomfortable for you, or getting, you know, uh, breast cancer screening as, you know, a trans man assigned female at birth may be uncomfortable. So it's our goal in the Cancer Center, aligned, you know, with the LGBTQ plus, um, you know, Center for Care in Cleveland Clinic, is to be able to provide you with this care in a culturally sensitive way, so that we can ensure that you're getting appropriate screening, that you're getting early detection, so that we can improve, you know, our cancer outcomes and save more lives. Because we know, like I said, early detection saves lives. So if we can get you screened and identify your cancer earlier, then we can, you know, hopefully, you know, cure your cancer or put you into a remission at an earlier stage. If you're interested in additional resources, um, you know, I've put these links here. Um, you know, the National LGBT Cancer Network, the Health Education Center, um, you know, Cancer Facts, for gay and bisexual men or lesbian and bisexual women on cancer.org, you know, all of the Safe Zone Project, all of these, you know, organizations have a lot of good information, and recommendations for those within, you know, our sexual and gender minority population. If you have more questions about what your risks are, what you should be doing for screening, what you should be communicating to your healthcare provider. But in general, you know, being open and honest with your healthcare provider. Um, hopefully, you know, hopefully all of your providers in Cleveland Clinic are, you know, providing you with a safe place to express your health concerns, express, your healthcare unique situation or risk factors so that we can work together to make sure that you are safe. And here are my references. Again, you know, these are our academic references, but um, again, there's a lot of good, research and education within these resources if you're interested in, kind of reading more about this topic. And that is all I have.